I'd like to welcome you all to the Health Risk Assessment Capacity Building session. This is part 2 of that session. We're going to have Amanda go over the Zoom housekeeping real quick and talk about interpretation. And then we'll begin talking about the material that we have to cover today.
Ya viene sido pasado algo de 5 minutos después de las 3 de la tarde. Vamos a comenzar con la presentación en un momento. Amanda va a dar algo de información de las instrucciones acerca de la interpretación.
Thank you, Matt. So we have Spanish interpretation available today via the Spanish channel.
Tenemos la interpretación ahora disponible que le vamos a estar dando en español el día de hoy.
If you'd like to access it, you can select the globe icon at the bottom of your screen, or if you're on a cell phone, you'll have 3 dots for a more menu and you can select interpretation there.
Si le gustaría acceder a la presentación, tienen un icono de un glóbulo hacia abajo donde usted puede oprimirlo, y si no, también puede subirse hacia el canal de la interpretación de español por el teléfono.
And as there may be questions in Spanish, we encourage monolingual English speakers to select the English channel now.
Y como si va a haber personas que lo van a querer escuchar en inglés, les pedimos a las personas que quieran escucharlo de eso, pongan su canal en el canal del inglés.
Right. And since those calling into the Zoom meeting today won't be able to hear Spanish translation, we also have a Spanish-only conference line.
Y también como aquellos que quieran escuchar la presentación, pero no van a estar por la plataforma aquí, pueden llamar al número de teléfono de conferencia para acceder a la presentación por el teléfono.
So in order to access that, you'll dial the number here on the screen, which is 866-803-2146.
Y para poder hacer eso, solamente tiene que marcar el número que ve aquí en la pantalla, es el número 866-803-2146.
And the passcode for that is 1083550.
Y el código de entrada es el 108350.
Again, that number is 866-803-2146, and the passcode is 1083550.
Y de nuevo, el número de teléfono para llamar es el 866-803-2146 y el código de entrada es el 108350.
Are there any questions about how to access translation today?
¿Hay algunas preguntas de cómo acceder a la presentación el día de hoy?
Okay, so we'll go ahead and end sequential translation now, and I'll add you to the Spanish channel, Leticia. Thank you.
Yes, of course. Ahora vamos a terminar ya esta interpretación por lo pronto y vamos a comenzar a lo siguiente.
Okay, so I'll try to get through this next part fairly quickly. Just some general Zoom housekeeping. If we can make sure that we're muted, if you're not talking, just to avoid any unnecessary interruptions. We also encourage you to rename yourself if you have an organization that you're representing. So in order to do that, you can hover over your image in Zoom and you'll see 3 dots in the top right-hand corner. And from there, you can select rename. You can also access that in the participant menu if you hover over your name there. And in order to mute and unmute, you should see a microphone in the bottom left-hand corner of your screen. If you're calling into the Zoom meeting, you'll dial *6 to mute or unmute yourself. And of course, we encourage you to use your camera if you're comfortable. That icon should be right next to the microphone. Again, for most people on their computer, it's going to be in the bottom left-hand corner of your screen. We'll also be using the raise hand feature today. So there's two places that this could be. It will either be under your participant menu in the bottom right-hand corner, or if you have a reactions option at the bottom of your screen, raise hand is there as well. For those who are calling in, you can dial *9. Unfortunately, we've had issues with our Zoom account in the past where this wasn't working. So we will check in with those on the conference line for English periodically and to see if there's any comments or questions. And we will also be checking on the Spanish conference line for that. We'll be using the chat feature today. So if you don't see that already popped up, there should be an icon in the bottom of your screen. You can choose to privately chat any of the hosts or co-hosts if you have a specific question, but in general, I encourage you to send the chat to everyone. Please just keep in mind that these chats are archived even if they're private. And then the last feature that we'll be using today is Poll Everywhere. So hopefully if you've been on with us, you've used this before. If not, Eugene just put the link for it into the chat. You can go to pollev.com/home, and then the username that you'll put in is crystalaza824 and select join. You can also text your responses to the questions to the phone number 22333. And again, you'll text crystalaza824. And we will go ahead and test the Poll Everywhere now. Again, if you don't see the link for it, Eugene just put it into the chat. So let me stop sharing. So the first question that you should be seeing is this one. You may have answered already. How much experience do you have with health risk assessments? We had quite a variety in the registration, so I'm interested to see if that's the same here. I think the majority was moderate, very little or no experience. Okay. And if you're having any trouble accessing this question, please raise your hand or put it into the chat. Okay, not seeing any raised hands. Looks like most folks here have very little or moderate experience. Nice, hopefully this will be a helpful session for you. Okay, let's look, we have one more question that we want to share before we get started with the presentation. So why are you interested in increasing your knowledge of health risk assessments? If you're not seeing that question pop up, try refreshing your page. Protect public health. Thank you. Pertinent to your job or career. Nice. Want to know more about how it can be used? Building capacity. Awesome. Environmental reviews for toxic exposure to communities and guidance. Duties of the job. Better understand the process. So it's relevant to patients, you see. Interesting. Work relevant. Advocating for public health equity. Nice. Better organizer and protect or advocate for the community. Awesome. Protect family and community. And better expand knowledge. Yeah, this is really helpful. I think this is helpful for Matt to see too, as he thinks about presenting the information. CEQA documents, good to know. Very nice. It looks like everybody's having an okay job accessing this polling. So again, if you have trouble with it, you can send me a private chat or you can raise your hand as well. But I think most people are able to access it. Awesome. So I'll keep this question open. So please feel free to keep responding. But for now, I'll pass it over to Matt to take over.
Okay, I'm going to share my screen here. Okay, can everybody see my screen? Excellent. Okay, I'd like to introduce myself. I'm Matthew O'Donnell. I'm the manager of the exposure reduction section in the Transportation Toxics Division at the Air Resources Board. I was asked to put together this presentation. It's based on some experience I have myself and input from community advocates that we reached out to. I'd also like to introduce, although she's already been talking a great deal, Amanda. She's more than just meeting support, which I think really estimates her importance to this whole process, but she's the one that keeps all of this going and coordinated. So if you're interested in reaching out to us to discuss future sessions of this type, Amanda is a good contact point. Today we'll also be having a short presentation by John Boudreau of the Office of Environmental Health Hazard Assessment, or WEHA. John is the chief of the Air Toxics and Risk Assessment section, and he'll be explaining WEHA's role in the creation of the guidelines that we use to conduct health risk assessments. Oh, a couple other things too. There are two other people that are on the line today that will be acting as panelists to help us answer questions. One is Stan Armstrong. He's our CEQA expert. So anything that I can't answer, he'll step in for. And for questions having to do with AB 617, we have Cassandra Lopina on the line today as well. So housekeeping assumptions. The basic assumptions that I made when I was putting this information together was that all of you have little to no experience with health risk assessments. And I created the materials with that in mind. So if you're familiar with this, some of this may be old hat for you. But if you find that you have things that you think would be helpful to say along with what I'm saying, please let us know. I'd be more than happy to have other people who are experienced with health risk assessment, specifically as it pertains to community advocacy, provide some additional input. So please feel free to do that. Questions. Questions are very important. The material that I put together is based on input that we got from the original request, and also from input that we got from some community advocates that we reached out to. But it is just the material that I thought might be relevant. The whole point of this session, the whole point of you being here and us talking in this way, is that we answer your questions, that we provide you with the information that you need to do your jobs, to advocate for your community. So the best way to make sure that we have provided you with that information is to ask questions. I've put together a number of slides. If we get through those slides today, great. But if we get through only part of the slides, but we answered all your questions, to me, that's much more important. So please stop me, raise your hand, ask a question. Even if that question isn't directly relevant to what I'm talking about at the time, I would rather you stop me and ask your question than assume that I'm going to answer the question later on in my presentation and then miss the opportunity to ask the question. So please, be the first brave soul to ask the first question so that everybody relaxes and we can have a conversation. As far as the agenda and flow are concerned, that is it. We have 2 hours today to go over this material. It's high level, but the flow is dictated by your needs. So if you want to ask questions, if you want to interject and provide your experiences, those are just as valuable as anything that I can say. So please don't assume that my presentation is the only way to get this information, or is the only way for this session to proceed. Okay. In the process of developing this material, we did reach out to a number of community advocates, and they were very generous with their time and their expertise. So I'd like to thank them personally. They are Genevieve Amsalam, Mark Abramowitz, Joe Liu, Jonathan Pruitt, Tim Tyner, Taylor Thomas, Melissa Vargas, LaDonna Williams, and Jane Williams. Again, they were all very generous, both with their time and their expertise, and we appreciate that a great deal. So thank you. So just a little bit about where we are in this process. So this is the second session having to do with health risk assessment and capacity building. The first session was held on back in December on the 14th. And at the beginning of that session, we actually invited two of the community advocates to speak in advance. And during that process, during their presentations, they expressed concerns that they had about the way health risk assessment is currently analyzed, the methodology that we use, and how we approach using the information that we get from that. And that began a very interesting conversation, which was very worthwhile. The conversation did take up a good portion of that time period, so we weren't able actually to cover all of that material. Those concerns that were expressed during that session, we intend to address in another session that's coming up on May 10th. That session is intended specifically to discuss those concerns, to have an open conversation with anybody who wants to attend. So you're all welcome to join us, but to hear those concerns and discuss what could be done to address those concerns. That is the whole point of the meeting on the 10th. The reason for scheduling this meeting today, this session today, was to go through the materials that we were presenting in December and make sure that all of you who are new to health risk assessments have a chance to hear that material and to provide you with some background and some foundational information so that you understand the way health risks are conducted today and how we use that, that information currently. So that when we get to the discussion on May 10th, you can participate and have that background information. Okay. So the objectives for the session today are just basically to provide you with useful information about health risk assessments to aid you in your advocacy. So we're going to do a very high-level overview of health risk assessments, and I do mean high-level. It's going to be there's not going to be a whole lot of technical in this one. This is a rather technical topic, but we're going to keep this at the 30,000-foot level. But we're going to go over the entire process so you guys understand just exactly the steps that we go through when we determine whether or not to conduct a health risk assessment, and then what to do when we do decide to do it. I'm also going to provide some background information about the air district's responsibilities and CARB's responsibilities. And the reason for that is it helps to kind of contextualize the information. It helps you to understand why districts conduct health risk assessments when they do and what they do with the information. And the same thing is true for CARB. We have similar goals, but we do different things. So it's helpful to understand what we do, because it helps you understand why we use health risk assessment and what we use it for. So in that context, we'll talk about CARB and our role, the local air districts, but we'll also talk about other agencies. And primarily here, we're talking about land use agencies, because those are the agencies that have a role in the CEQA process. So that's relevant to them as well. So we'll talk about something called Assembly Bill AB 2588, which is a piece of legislature that was passed. It's typically referred to as the Hotspots Act. It's the shorthand name for it. Oftentimes you'll just hear it referred to as AB 2588. We'll talk about something called new source review. That's something that's done at the district level, and they oftentimes use health risk assessment when they're going through new source review. We'll talk about the California Environmental Quality Act, or CEQA, and the role that health risk assessment has in that process. We'll also talk about rule development, and specifically here, we're talking about CARB rule development. And then time allowing, we'll talk a little bit too about assessing community risk. And by this, we really mean cumulative impacts analysis, and where we are with that and where we hope to go. Okay. So any questions on that so far? Okay. Hearing none, I'm going to keep going. Okay. So we'll talk a little bit about how HRAs can be used by those of you in the community as community advocates, and to advocate for support of your programs and to address your concerns. We're starting with community advocates in particular. We invited primarily community advocates to the first session and this as well. Mostly because the topic in this particular case is not one that's easily consumed by everyone. So we didn't open it up to community members at large, the general public. What we're hoping for is that as we go through this process and as we have more sessions of this type, we can get feedback from all of you as to whether or not this is a topic that you think would be appropriate to share with the community at large. And if so, how best we can tailor it to their needs. So your feedback on ways that we can tailor it and improve it's going to be very helpful to us. So we ask that you might help us out there, keep this conversation going. Okay. So we're going to basically cover the what, when, how of health risk assessment. So when we talk about health risk assessment, when we say HRA, for the purposes of this conversation in particular, we're talking about an evaluation that's done per the OEHA guidelines. So the Office of Environmental Health Hazard Assessment has created a set of guidelines for conducting health risk assessments. It has a very long title, but generally we refer to it as the OEHA guideline. So that specifies just how that type of evaluation is done. It's important to note that that evaluation is a tool. And like any tool, it can be used properly. It can also be used improperly. So the tool itself, there may be things that we can do to improve the tool itself, but one of the things that we have to be aware of is there are people using this tool, and those people need to understand properly how to use it in order to get good results. It is, however, just a tool that estimates risk. It estimates cancer risk and non-cancer, chronic and acute. It is conducted when you have one or more toxic air contaminants or hazardous chemicals, if they're being emitted by a facility, but only if the emissions from that facility exceed a certain threshold. And we'll talk about what those thresholds are. The whole reason for the tool is to provide us a score. And we get three different numbers, or potentially three different numbers from the health risk assessment. One is for cancer, and there are potentially two, for non-cancer chronic and non-cancer acute. And we don't always get all three, so be aware of that. But the whole point was to provide us with a score that we can then compare to a standard. And that standard indicates whether or not the facility has to take further action to reduce their emissions. They may have to notify those in the area around the facility of the risk. Or if it's an application for a new facility or a new operation or new permit at a facility, that standard may determine whether or not the district allows or denies that particular permit application. Again, this tool is only as good as the information that you use to run the analysis. And that's an important thing to note. And that's really kind of, I think, the underlying reason behind those concerns that I mentioned earlier. It is not a hard and fast. There is a fair amount of discretion left up to the modeler and the person conducting the health risk assessment, because it's necessary. They have to make certain decisions. So even if two people of equal capability run the exact same analysis, they may get slightly different numbers, but they should only be slightly different. They shouldn't be significantly different. Okay. So any questions on that so far? Any hands raised or? We do have a question in the chat. Okay. So, it looks like we have a couple of hands as well. So Mary Elizabeth, if you want to unmute yourself and ask your question.
Yeah, this is the same question in the chat. What about the cumulative risks? So this is, project by project, but then, every little bit overlies.
Yes, correct. Absolutely. Yeah, and that is one of the things that we need to address. Health risk assessment as it stands right now, whether it's for 2588 purposes or for permitting purposes, is source by source or facility by facility. Cumulative impacts is one of those things that we're going to have to deal with. I talk a little bit about it at the end, but we can talk about it now too. We don't currently have, neither ARB nor the air districts currently have policies or procedures for how to do that. And we're all very aware of the fact that we're going to need to do that, and we're going to work to develop those. The pathway to that hasn't been well defined yet, but we at the ARB are currently in the process of evaluating how we're going to do that. We're looking for tools, and we're going to start the conversation with all of you, with any community advocates that want to participate in the process, and with CAPCOA, or the California Air Pollution Control Officers Association, to develop the means to do that. Did that answer your question?
Yes, unsatisfactorily, but yes.
Yeah, I'm sorry. Yeah, I suspect that that's going to be the case. I mean, we can't say that we can do it right now, but we know that we need to do it, and we're working on getting to that point. I apologize for that. So Margot, do you have a question? You can unmute yourself and ask.
There we go. Yeah, so I put in the chat as well. So it sounds like from what you're describing, the risk that's already predetermined, that's already set by some standard. The standard is set as to what's allowable. And that's what you're scoring. That you're scoring, you're pulling up the data, and you're going to score what the risk is. Now, the risk is already predetermined. So someone has determined what is allowable.
Yes. Yeah,
For
those are answers,
cancer
yes.
or non-cancer. And so does that change? Do those standards change when new information comes in? And does California even monitor cancer cases these days?
Well, it's really hard to directly connect the results from a health risk assessment with actual cancer cases. But I'm going to ask you to let me get to that here actually in a little bit. It'll be easier to explain once I've covered some of that. The short answer to your question is yes. So a health risk assessment is intended to predict the probability of cancer risk and the probability of non-cancer, chronic, and acute health effects. The numbers that are produced by that process, by that health risk assessment, are compared to a standard, and that standard is determined by each of the air districts individually. If we're talking about the permitting process. So yes, there is a pre-existing standard. It varies to some extent from district to district, but there is, I suppose, what you could say is an allowable level of risk. I hope I answered your question. If I didn't, please let me know. Okay. Were there any questions in the chat?
There was, but I think they were both covered.
Okay, sounds good. And were there any questions in the Spanish room? Okay, nothing. Okay, so I'm going to talk about now the steps in the health risk assessment process, starting with prioritization, and then we'll get into what a refined health risk assessment is. So these are the steps. This is the way it works. With every facility, any facility that is potentially emitting hazardous air pollutants or toxic air contaminants or hazard chemicals, we calculate what's known as a prioritization score. And that score lets us know whether or not that facility needs to be subject to further inquiry, further examination. The next step in the process can be something called a screening risk analysis. You may hear that term. A screening risk analysis is essentially a health risk assessment using health protective assumptions. Assumptions about the source of the pollutants and assumptions about the meteorology used to do the air dispersion modeling. They're typically more conservative than a refined health risk assessment. So the idea is that you can run them more quickly. And they will let you know if you, for instance, if you run a screening risk analysis and all of the scores are below the action thresholds, that if you do or find risk assessment, the results will be even lower. So it's just a way of sort of shortcutting the process and making it faster. But the prioritization score may also require that you do a refined health risk assessment, and we'll talk about that here shortly. So we'll start off with prioritization. So again, a prioritization score is, again, a very simplified calculation that allows us to determine whether or not the emissions coming from a facility are so low that we know that it's not going to be a problem. That's really the bottom line. It also allows us to determine whether or not they are so high that we definitely have to look at them. So that's really the idea. It's just a quick calculation that allows the air district to determine whether or not a facility needs to do a refined health risk assessment. Okay. In the health and safety code, it says if a facility is categorized as high priority, the facility is required to submit a health risk assessment to the district, and that health risk assessment has to be prepared using the Office of Environmental Health Hazard Assessment guidelines, the OEHA guideline. So it's very specific about what has to happen. Again, one of the things to note here is that the health and safety code puts the onus of conducting the health risk assessment on the facility, not the district. So that facility is likely, there's very few facilities have the capability in-house to do that. So they are likely going to hire a consultant to do that. Once completed, that health risk assessment goes to the air district, and the air district reviews it for completeness and accuracy. And then once the air district is done reviewing it, assuming they have no comments that need to be sent back to the applicant, they send it on to the Office of Environmental Health Hazard Assessment, and OEHA has the opportunity to review it as well. Okay. So how do you conduct prioritization? That's a really good, question that everybody was asking after this first came out. And as it turns out, the Health and Safety Code doesn't specify it. What it does say in Health and Safety Code is that basically what it says is somebody who knows what they're doing should come up with a method. That's the shorthand. The group that did that was the California Air Pollution Control Officers Association. They came up with the CAPCOA Air Toxic Hotspots Facility Prioritization Guideline. That was back in the 90s, the early 90s, or late 90s rather.
Matt?
Yes.
There is a question and there's a hand raised.
Oh, sure. I'm sorry.
Jonathan Pruitt.
Hey, John.
No, it's totally fine. I'll wait till after Matthew.
Oh, okay. Sounds good. Well, don't let me keep going. Okay. Wave your hand or something. So anyway, the most current version of the prioritization guideline, the CAPCOA guideline, was published in 2016, and there's a reason for that. The OEHA guidelines changed in 2015, and I think John's going to talk about why that was when we get to his presentation, Jonathan Maduro. The whole point of the prioritization guidelines were to assist the districts in prioritization scoring. Now, it's important to note that it's intended to assist them. It's like the pirate code. It's more of a guideline than an actual rule. So the districts aren't actually required to use this particular guideline. It was published collectively by CAPCOA to provide the districts with something to use. They can choose to use it. They can choose to take what's there and modify it, or they can choose to not use it at all. Most districts do use it. South Coast, for instance, uses something very similar, but they add a couple of additional terms to the calculation. Some districts don't use it; they use an entirely different method. But the whole point of the methodology is to provide a separate score for cancer, for non-cancer chronic, and non-cancer acute. Now that probably sounds very much like what I just said about health risk assessment, and there's a reason for that. We wanted to know if we have to conduct a health risk assessment for any one of those things. So the scoring methodology gives us a score for each. Okay. That calculation is actually really simple. We calculate what's known, it's a unitless score. There's no units to it for the whole facility. So this is always a facility-wide score. We do that by taking the emissions of each toxin or hazardous chemical and giving that a score, and then adding those all up, and that gives us the total score for the facility. That calculation is based on simply the emissions rate of the pollutant, whatever it is, whatever that toxin is, just the emissions rate of that pollutant, the unit risk if it's a carcinogen, or the reference exposure level if it's a non-cancer, acute, or chronic toxin, and then the distance to the receptor. There's a couple little things in there that are used to modify it, but that's basically it. So just to kind of give you an idea of what that means, I put together a little diagram here to kind of go over. I don't know if you guys can see my cursor or not, but the dashed line represents a property boundary. We have a receptor just outside the property boundary on the right, and then there are 3 sources. So let's assume or pretend that source 1 and source 2 are both emitting the same carcinogen. And then source 3 is emitting a non-carcinogenic toxin that's got a chronic value. So it's a chronic non-carcinogen. Okay. So what we would do is take the rate of emissions of that carcinogen coming for source 1, multiply it times the risk factor, and multiply that times the distance to the receptor. Do the same thing with source 2, emissions rates, unit risk, distance to receptor, and then add those 2 up, and that gives us the total cancer risk score for this facility. And then for source 3, we would do the emissions rate of that chronic toxin times its reference exposure level times its distance to the receptor, and that would give us the chronic score for the facility, entire facility. That's very simplified, but that's how it's done. It's a really simple calculation. Once we have that number, we then need to figure out what that means. Where does this facility fall in the overall scheme of things? Is it a high priority facility or not? So to do that, also in the CAPCOA guideline, there is this recommended scoring methodology. So for any facility, and again, it's the entire facility, where everything, cancer, non-cancer chronic, and non-cancer acute, is less than 1, that facility is considered low priority and they're basically done. They have to do the quadrennial reporting for their emissions inventory, but they have nothing else. For facilities that are greater than or equal to 1, but still less than 10, those are categorized as intermediate priority facilities. And those are really kind of left up to the districts. The districts have a fair amount of discretion to decide what to do with those facilities. They can ask one of those facilities to conduct a health risk assessment, but the facility isn't necessarily required to do that. And then for facilities that are greater than or equal to 10, this is prioritization score, not 10 in a million for cancer, but just a prioritization score of 10. And that can be for anything. That can be greater than or equal to 10 for cancer, or for non-cancer chronic or non-cancer acute. If any one of those scores is above or equal to 10, that facility is considered high priority, and that facility then has to conduct a health risk assessment. Okay. Any questions on that? Jonathan, do you have a question? Or? You're good? Okay. Juan? Oh.
Okay, cool. Thank you. Okay, so say a project was proposed back in 2008, maybe even 2005, and they provided a health risk assessment. The health risk assessment showed that there was no risk, but it was really close to the threshold. Unfortunately, the project, fell through, and it, something happened behind the scenes. But all of a sudden, in 2022, the project comes back.
Okay.
Are they supposed to go and do another health risk assessment, or can they still use that old one?
My reaction, and you're going to have to talk to the district about this. My reaction is no, they can't use the old one, and the primary reason is in 2015, we have revised the calculation methodology, and it significantly changed residential cancer risk scores. So they would have to go back and reevaluate that using the new guidelines, for sure. And then if there were any changes to the modeling that needed to be done, I can't remember when we adopted AirMod, but it may have been before that. But if they didn't model using AirMod, I would imagine that the Air District would also require that they go back and remodel and not use, because its predecessor, which was called ISC ST3, doesn't provide the same level. AirMod's a little more conservative, provides slightly higher concentrations, so that they would probably want to see that as well. Did that answer your question? Okay. I can't speak exactly for the Air District, but that would be the way I would think things are going to go. So, Una? have a question? You there? Can you unmute or? There you go.
There we go.
Yes, from the previous slides, from
Mhm.
your previous slides,
Mhm.
you mentioned in calculating prioritization score,
Mhm.
it seems like the sources and the receptor is outside the property boundary. So if there is a facility, something like a hospital, where the receptor, something like a coffee shop or anything located within the property boundary, how would you suggest doing the prioritization score, or would you just use the same method from your slides? And if the prioritization score is less than 10, and then the facility doesn't need to do Harris assessments.
Yeah, that's correct. So typically, receptors that are on site are under the purview of CalOSHA. So their
Okay.
exposure is regulated by CalOSHA, but that's only if they are an employee of the facility that's emitting the pollutant.
Yes.
There are plenty of examples of situations where, and actually, interestingly enough, two of them are universities and prisons. They have that in common. There are plenty of situations where there are emissions coming from the operations of, say, a university, but there's a food court on site, and that food court employs people who are not university employees.
Yeah.
In that case, you would be looking at their on-site exposure. So the receptor would be within the property boundary.
So you're saying that we should calculate those receptor in calculating the prioritization score.
Yes.
Even though they are inside the property boundary.
Yeah, so long as the person who's being exposed is not an employee of the facility. And I know that's kind of a strange thing to take into account, but the employee status makes a difference when it comes to the protections under CalOSHA.
Okay, thank you.
Yep. And then Moses?
Matt, before we get to Moses, we have a question in the chat from Earl Withcomb.
Sure. I can't read it, so Chelsea, if you would.
Yeah, let me unmute him.
Oh, okay. Earl.
Can you hear me?
Yes.
You mentioned that the prioritization score is the product of the emission rate, the unit risk factor, and the distance to a receptor.
Mhm.
That seems counterintuitive because the farther away that a receptor is from the facility, the higher the risk using that equation.
It's if you look at the equation, I didn't actually represent that properly, but the distance actually is inversely proportional. It's not directly proportional.
Well, I thought, my question was, wouldn't you divide the emission rate times the, okay.
Yeah,
I
sorry about that.
appreciate
Yeah. I misspoke. I apologize.
Okay, no problem. Thanks.
Yeah. And then Moses, I'm sorry.
Okay, and Moses.
There, can you hear me?
Mhm.
Oh, okay, cool. Thank you. My name is Moses Huerta. I live in the city of Paramount. I'm also a former public safety commissioner here in the city. That slide, Matthew, that you see right there, the first one, the source 1, source 2, and the receptor is actually what I'm living right now. You mentioned the hotspots earlier report. 2 of the facilities that are on that hotspot report that was published 2020 in my local air district are less than 200 yards away from my home. Actually, the backdrop, those I have video, you can see in my backdrop, those are the buildings that I can view from the top of my roof from my home. So I was in reference to the question of within the boundary, I guess if you can re-clarify again, if I am the receptor and I am right outside that line, I literally am feet away from the fence line. How, as I go forward and try to advocate, and that's what the useful tool that I like to how better to communicate. How can I, again, can you re-explain it again? If this is within their boundary and this is a calculation, how do I calculate my experience and say, okay, I've been seeing this, I've been feeling it.
Sure.
How if that makes sense.
Yeah, it does. Yeah, no. Because of the way AB 2588 is structured, and because prioritization score is intended to address AB 2588, the sources that we're referring to are all sources within one property boundary or under the ownership of one facility. So this would be a facility score. So it wouldn't be, multiple facilities that are owned by different people. I just want to make that part clear. The calculation's actually fairly easy to do. And actually, if you want to, what we could do is, after we're done here, maybe tomorrow or something like that, I can contact you and I can actually run through the prioritization guidelines and we can talk about how to do that properly. But it's really straightforward. But it'll give you an idea of any one facility's impact on you. Or actually, I take that back. It's not going to give you a really good idea of any one facility's impact. It's going to give you an idea of whether that facility should do more to quantify their impact. They should do whether or not they should do an HRA. Okay.
Sorry, thank you, Mike. Yeah, that's kind of what I'm getting to, where we can getting to the facility if they have to redo it, especially with the new calculations, especially with the week, because I participated in that Cal Enviro 4.0 a couple years ago in that implementation, getting new calculations. So I'm this is giving me I guess a little more to understand, but I appreciate the opportunity. I definitely would like to have that conversation if that is possible. Thank you.
Yeah, absolutely. It'd be my pleasure. Yeah. And then Rich, I believe we have your hand up.
Yeah, my question is the emissions rate based upon a peak or an average? Is it annual emissions, peak hourly, or?
It's been a while since I've done it, but I'm pretty sure it's annual emissions.
Okay.
Almost entirely sure. I'd have to go back and double check that, but I think it's pounds per year.
Okay.
So it's annual emissions, yeah.
All right, thanks.
Yeah. And then Nish?
Yeah, hi. So question, is a health risk assessment done if any one receptor has like a health risk of 10 or more? Or so in this example right here, right, like that, there's not one receptor, but if there is, let's say that receptor is like a tiny coffee shop or something, but then a few, I don't know, mile away or something, there's like a large school or a library or something like that, and that the risk factor for that facility is low, will the health risk assessment still need to be conducted even though just that one small facility will have like a high health risk?
Yeah, so I should have actually looked into this. I don't think we differentiate worksite exposure from residential exposure in prioritization. If there is a receptor nearby, and that I believe can be a worksite receptor. I'm going to have to double check that one for you guys. But it's the nearest receptor. We just go to the nearest receptor and calculate that score. So it's sort of independent of whether or not it's residential or whether or not it's what you might call a sensitive receptor. We don't differentiate, a worksite from a residence, from daycare or anything like that. It's just the highest score that we can find.
Got it.
Yeah.
Thanks.
Yep. Okay. And then Winnie, did you have another question?
Yes. I just have one quick question. So if that receptor on that slide is something like a building and the distance is somewhere between, let's say, something like 90 meter and 100 meter, where the prioritization score, if you calculate it using 100 meter, drops significantly when you use 90 meter. What are the rule of thumbs in using the appropriate distance? For instance, do you use the center of the building for appropriate receptor distance, where do you just use the very edge of the building where it could be less than 100 meter? What would be the rule of thumb, like appropriate approach?
To be honest with you, I don't think you're going to find that much of a difference. between, you know, the edge of a building and the middle of a building.
Okay.
As far as the calculation goes, there have been a lot of discussions about how to use this properly. If you read the guideline and follow it strictly by the letter of the guideline, what you would take was the distance from the source to the nearest property boundary, and then the distance from the nearest property boundary to the receptor to there. And those are the two distances you would use, rather than the distance directly from the source to the receptor. But there's some discussion about whether that's really the intent. We have in the past, I've seen, you know, people go from the center of the source, you know, if the source is a building, for instance, and it's, we would normally call a volume source where there's no stack per se.
Okay.
We would go from the nearest, you know, wall of that building where there would be an opening to the property line of the next receptor. Because you can never say for sure whether someone might be on the edge of the property, you know, for some reason, for some legitimate reason. So we usually just go to the property line. If it's a stack, it's much easier to do. The center of the stack is the location of the source. So I mean, I guess if you're like really close, if you're at 9.5 when you're, you know, at the center of the building, you'd probably want to be conservative and go back to either the edge of the building or the property line and see if it gets up to 10.
I see.
Yeah.
Yes, because if the distance is, let's just say 99 meter, and the distance is 100 meter, it's like more than half or something like that, because of the receptor proximity numbers, you know.
Yeah.
So
yeah.
that's where my intention is. So let's say the facility is between 90 and 100 meters. So when using 90, it will give me, let's just say 11 or 12. But if you're using 100, that will just give me like only 5 or 6.
Yeah. I mean, I think the best, well, you're with a district, are you not?
Yes, I am.
Yeah. I mean, I think in most cases, you're going to want to use the most conservative number.
Okay. Got it.
There are also actually, I mean, I've really oversimplified the prioritization scoring methodology. There are a few more terms in there, and there's actually 4 different versions of how to accomplish that scoring. Typically, most districts will calculate it using all of the methods and then pick the highest number.
Oh, okay.
I mean, that's just because it's the most conservative.
Okay.
So
I
would stick with whatever number is, I mean, is most conservative that you can, you know, reasonably justify.
Okay.
That's just
Thank
my
you.
advice, you know, so.
Thank you.
Okay. Any other questions? Okay. Okay, so we've talked about prioritization and how we determine whether or not a health risk assessment has to be conducted. Once we've determined that we need to do a refined health risk assessment, we need to know what that involves. So to talk to us today about the guideline itself, how the current version was developed, and the role of the Office of Environmental Health Hazard Assessment, we're joined by John Boudreau. And John, I've got these up, so I will mute and you can take over.
Okay, and I'll be referring to the Office of Environmental Health Hazard as OEHA through the presentation. Just a bit easier on the ears. Next slide, please. And just to give you an idea, OEHA is one of 6 of the 6 California Environmental Protection Agency departments. Next slide. Now, OEHA's role in the air toxics hotspots program. We're mandated to develop risk assessment guidelines for facility health risk assessments. And these guidelines are used in evaluating the potential health impacts from stationary sources of air pollution to people nearby. And these risk assessments include estimating cancer risk and non-cancer health hazards from exposures to chemicals that are emitted by those facilities, which are, you know, often say industrial plants or chrome plating shops, you know, things like that. And we also review facility health risk assessments for the air districts. Next slide. So the core of the hotspots risk assessment guidelines are the technical support documents, or the TSDs. And there's 3 that we're currently using. They were all developed after consultation with both CARB and CAPCOA. They received public review and external scientific peer review by the scientific review panel. And the 3 most recent versions of the TSDs that we adopted were in 2008, the non-cancer reference exposure levels TSD. And that describes our non-cancer risk assessment methods and the chemical health values generated using those methods. And the reference exposure levels are often referred to as RELs. In 2009, the cancer potency factors TSD. This describes our latest cancer risk assessment methods and the cancer potency factors developed using that methodology. And then in 2012, the latest version of the exposure assessment and stochastic analysis TSD. And this outlines the methods used for determining resident and off-site worker exposure. Next slide, please. And these documents were all came together for the risk assessment guidance manual, which was the most recent version was adopted in 2015. And one thing that's notable about it is includes age sensitivity factors. The guidelines that make cancer risk adjustments for infants and children. Infants and children are developing much more than adults are, and early life exposure tends to result in the greater possibility of developing cancer if you're exposed to a carcinogen. So basically, the guidance manual combines the information from the 3 TSDs into a user manual for conducting health risk assessments. And that concludes my presentation. Matt?
So any questions on what John was talking about?
If there are no questions for John, are there any
It looks like Moses might have one.
questions on the conference line? To unmute is *6. Okay, Moses, let me unmute you. There you go.
Thank you, John, for the PowerPoint. In reference to some of the guidances, so we also using data from like NIH, any of those federal agencies that do deep dive studies on these effects, especially more like on the community level? I hope that makes sense.
The bulk of our health values, be they cancer or non-cancer, are pretty much animal studies that were done by a variety of organizations. A lot of them are government studies like National Toxicology Program, but sometimes there's actually organizations that do studies or even industry studies. We also will base health values on human data if we've got it. Most of the time those would be occupational studies, because those are people that are exposed to like a single chemical that you can zero in on for a long period of time at relatively high levels. So NIH doesn't do the kind of studies that we would need to do to develop a chemical health value, pretty much.
I see. So my understanding would be, if I may use as my example, I grew up next to the facilities here, 40-year exposure. I am cancer positive. It's something that has been documented. So that would be more of what the NIH would not have that information, or down to the level, say for my as a receptor, we would then do more of that studying. And how much data going back are we going to see a historical information on the data to say, is that in the manual to say we could see historical exposure, say in my personal experience, seeing that data and saying it culminate to this point?
Well, the facility health risk assessments that get done according to the guidance manual are basically snapshots in time. You know, they look at, for a particular emissions inventory year, what was poured out in that given period of time, what were the weather conditions, for example, and how does that model what kind of air concentrations do you think were experienced by the community? So I don't know that there's a real look back in time as far as what's been going on. And the reason why NIH or any other organization wouldn't look at tend to look at a facility in a community is that, facilities often put out a number of different chemicals. So even if you get results back, it's hard to attribute them to a particular chemical. That's why you tend to see, if you've got human data, occupational studies used a lot, because workers might be exposed to one or two chemicals, say. So it makes it a lot easier to tease out what's actually causing the effects. And that would be tough to do in a community setting.
Right. So you would get more cooperation from companies in doing the employee studies, would companies be reluctant to, say, participate in that type of information?
Well, a lot of the occupational studies wound up being conducted by government agencies such as NIOSH, which is the National Institute for Occupational Safety and Health. So a lot of those, there have been some industry studies that we've used, but most of the time they're government studies.
Okay. Thank you. Thank you, John.
Okay. Any other questions? Okay. I'm going to go ahead and move on. And if you do have some questions, feel free to stop me. Okay. So we've gone through the process of determining whether or not a facility needs to conduct a refined health risk assessment by conducting a prioritization score. We're going to be using the WEHA guideline to conduct that refined health risk assessment. So let's kind of talk a little bit about what that is, what a health risk assessment is. And again, this is going to be kind of high level, so ask questions, please, if you want further explanation. This is the document that John was just talking about. This is the Office of Environmental Health Hazard Assessment, Air Toxic Hotspots Program, Risk Analysis Guidelines, Manual, blah, blah, blah. You see the whole thing. That's why everybody calls it the WEHA guideline. Okay, so health risk assessment. So refined health risk assessment really is always conducted in three major steps or three major parts. It begins with air dispersion modeling. The most common model used for conducting air dispersion modeling is a program called AirMod. And that's for two reasons. One, it's the US EPA recommended air dispersion model. And also because of the models that are available to us for conducting this type of modeling, it is one of the easiest to use and gives us results most quickly. And that may not seem like a good thing to point at, but the AirMod is actually a very good model. It does predict ground level concentrations very well. And it's been tested. I mean, it's been tested against monitoring station data. So it is a good predictor of concentrations. But one of the things that's important about health risk assessment is that we can get them done and use them. And other types of programs can take quite a bit longer and require a good deal more information to use. That program, or any program, any air dispersion model, is going to give us what are known as source-specific concentrations. So what happens is the modeler inputs all the information about the sources, and then that modeler, he or she, will decide where they want to put a series of receptors. And what the program does is calculate concentrations at each one of those points, what we call a receptor, in the model. But the dispersion model gives us what are known as source specific. So it'll tell you what the concentration is at any one point from this source, and then from this source and that source, but not all of them together. What we want to know is what is the concentration at any one receptor of any one pollutant. That's what's the most important to us. So the next step in the process is something called calculating or pollutant specific ground level concentrations. And that can be done in a number of ways, but the simplest way to do that is to use a program that we provide, a program called HARP2. It was written by CARB staff and is available to the public for free. It actually does include AirMod. So you never have to actually purchase AirMod if you don't want to, but it includes AirMod, and then it has the ability to calculate those pollutant specific ground level concentrations. And then based on those ground level concentrations and knowing the specific pollutants, it'll calculate the risk for us. So it'll give us, again, cancer risk, non-cancer chronic, and non-cancer acute, assuming that there are pollutants that have carcinogenic values or non-cancer acute or chronic values. So that program is capable of doing all of that for us. Just to give you an idea of what the output of a dispersion model looks like, this is what you get. This is the output of AirMod. This is from a company called Lakes Environmental that produces a graphical front end, a user interface for AirMod. What you're seeing here is a series of lines. The black lines are what are called isoplests. They're lines on which every value is equal. So what you're seeing is concentrations. And the nice thing about these is that you can overlay them on a map and see exactly what's being affected. The thing that you have to be aware of, though, is with air dispersion models, all you're seeing is concentration from any one single source at a time. So if you have multiple sources at a facility, you can only look at the concentrations for each source at one at a time. And all you really know is where the highest concentration is. It really doesn't give you any real information about risk, except that you can kind of predict where the highest risk will be. You have to go through the next two steps in that process to find out what the risks are and where those risks are located. So again, you can do that using our HARP2 program. We used to provide training on how to use HARP2. We have sort of outsourced that, if you will, to the local air districts to continue to train their folks internally. I don't know if any of them will be providing that training to the public, but that's something that we can explore and find out for you. Again, this program will do those next two steps. That being said, you don't actually have to use HARP2 to do that. You can calculate everything that the HARP program does manually. And in point of fact, when we're developing a health risk assessment for a regulation here at CARB, we actually don't use HARP2. We use spreadsheets because we're typically looking at a number of years, and we're also changing emissions rates over that time. So it's actually more advantageous to do that either in a spreadsheet or a database, but it's there and available for people's use. I want to talk a little bit about those changes that John was referring to in the OEHA guideline that came into effect in 2015. So the single biggest change, the most important change, was the change to the way we calculate residential cancer risk. Okay, so there's three types of cancer risk that we can potentially calculate. We can do worksite exposure, which is an offsite worker, residential cancer risk, or population-wide cancer risk. But the change that is most important is to the residential cancer risk score. And I don't expect you to remember these equations, but I have them here just to sort of point out the important parts. So with cancer risk, we always have two calculations. The first thing we do is calculate a dose, and then we calculate the risk from that dose. And that dose can be through a number of pathways. It can be by breathing it in, it can be by swallowing, it can be eating something. But this is an example of the dose for air, so it would be inhalation. So if you notice, there's a breathing rate over body weight, the BR over BW. So in the old methodology, we assumed one breathing rate and one body weight for your entire lifetime, whole 70 years. But part of the information that came out of the studies that resulted in the changes in 2015 was that the recognition that children breathe a lot more rapidly than adults, and they take in and exhale more air per kilogram of body weight than we do as adults. So that means that their dose is higher. So this accounts for that change or that difference with children. And then for the risk, we've added two additional terms. The most important one is this ASF, or age sensitivity factor. So based on the research that OEHA looked at, they determined that they needed to adjust the risk for situations where children are exposed. In essence, it is a recognition, or it is not in essence, it is a recognition of the fact that when someone is exposed to a carcinogen earlier in their life, they're more likely to develop cancer than if they're exposed to that same carcinogen later in life as an adult. So they came up with a series of age sensitivity factors. So the way this is done now is that these two calculations are done multiple times for a series of age bins and then totaled up. And those age bins are the third trimester of pregnancy, from 0 to 2 years, from 2 years to 16 years, and from 16 to 30 or 16 to 70 is appropriate. And those age sensitivity factors are 10 for third trimester through 2 years. So it would be a multiplier of 10, an increase, a 10-fold increase in cancer risk. 3 from 2 to 16, and then after 16, you're considered an adult, and it goes to 1. So we run this separate calculation for each of those age bands, total that up, and that's your lifetime exposure. That's your lifetime risk. But one of the things, there's a couple of things that you need to keep in mind about these calculations, this prediction of cancer. First of all, it's a probability of developing cancer. It's really, really hard to make a direct connection between the probability that's predicted in the modeling and actual cancer cases. It's just very, very hard to make that connection. And when we present that information, we present it as the number of cancer cases out of 1 million people. So what we're saying is there's an increase in probability of a certain number of people out of 1 million people, and that's how that's expressed. Also, we lump together all types of cancer. We don't differentiate cancer types at all. And the reason I'm pointing that is because there's a difference when we talk about non-cancer. Okay, so one of the things you'll never see happen is, as a result of an analysis like this, someone saying an individual person's probability of getting cancer is higher. We won't say your risk has just increased by 50%. It's always going to be expressed as a number of people, a total number of people out of 1 million. Okay, because we just have no way to draw a straight line between exposure and actual cancer risk. There's just too much uncertainty built into that. We do use conservative health protective assumptions, and there are quite a few places along the way where we use conservative health protective assumptions. We attempted to, and when I say we're talking about OEHA, CARB, and CAPCO all collectively, to come up with a system or come up with calculations and assumptions that are health protective, but not overly so. We don't want to really over predict everything. And the reason for those assumptions is because there is a great deal of inherent uncertainty in much of what we use, or many of the things that we use when we do this type of analysis. So it's just intended to cover up, or not cover up, that's not the right term, please forgive me for that one, to account for those uncertainties. And one of the things that John mentioned was oftentimes the risk numbers for both cancer and non-cancer are based on animal studies. Well, there's a fair amount of uncertainty about how those numbers would translate from animal population to a human population. There's differences in physiology, so there's some uncertainty there, that type of thing. But the whole point of the analysis is to give us a reasonable number, a reasonable prediction of the probability of increased cancer risk, so that we can then compare that to a standard, a threshold, to determine whether or not either a facility that's in existence needs to do something to reduce their cancer risk and their emissions, or if a new facility is being proposed, whether or not the air district is going to permit it as proposed. In other words, if it exceeds it, if it's a brand new facility and the facility-wide cancer score exceeds the threshold value, typically 10 in a million, but not always, then they may deny the application, and the facility will have to, figure out what they're going to change to make it possible. Okay, but again, the whole point is have one method that everyone is subject to. We use it in every case, and we compare it to the same standard within every district. So, everybody comfortable with that explanation? Any questions?
There's a few questions in the chat that I'd like to read. Moses would like to know how to find out if his local air district has a training program.
That's a good question, Moses. You're in South Coast, so you could probably contact South Coast directly and find out. I'm pretty sure so a little history. I used to teach a HARP 2 class. I used to actually teach different classes when I was working in the enforcement division. And when I moved to TTD, I was no longer able to do that. So we actually brought together a number of folks from different districts, and I trained them how to train. So, and I'm almost positive there was somebody from South Coast there, but I can't actually be positive of that. But you can check with them. If they can't give you an answer, get back to me. I'll probably put you in contact with a woman named Lisa Bush in the enforcement division, and we can get an answer for you. Okay, excellent. LaDonna?
There's a second question in the chat before Donna.
Yeah.
Jonathan asked, for a project's health risk assessment, are they required to actually show the whole equations, or do they just show the results of the calculation? And are we to assume they did it correctly?
I don't think there is a specific requirement that they show the calculations. They do have to show the results of the calculations. And if we're talking about AB 2588, they have to provide the input files and the output files. They can be both in printed form and electronically. To address your last question, no, we don't have to assume they did it correctly. I think it's worthwhile to assume that they didn't. And I don't mean that to suggest that every modeler or every consultant is intentionally trying to make things better than they are, or mislead people. But it's always good to look over things, make sure that their assumptions are correct, that they're consistent, that they're consistent with what you're seeing in your neighborhood or the nearby facility. So I would definitely, the whole point of the review by the district is to ensure that they did it properly and double check those.
Hey, Matt, I can also say that when we are reviews of facility health risk assessment, we actually go back and we have to have the at least the HARP2 files, if not the AirMod files also. And we actually rerun it through HARP2 to make sure that they are actually getting the results that they're putting in the HRA report.
Thanks, John.
Okay, and LaDonna?
Yes, I was trying to write down what you said. You said it kind of fast, and I tried to follow the wording on the screen. So I might be misquoting you, but I wanted you to repeat it. Sound like you said something to the effect that when you're doing these determinants, everyone is kind of determined by the same method. Did you say something similar to that?
Yeah, so what I was saying is the reason for coming up with this methodology was that we had a single method for calculating cancer and non-cancer health risk, so that we didn't have some people doing it one way and some people doing it another, and then taking those results and then comparing them to a standard, and then that standard, is the same for everyone within at least the air district that they're in. Different districts have different standards. I mean, so it could be 10 in a million, it could be 100 in a million, it could be 20 in a million. That's the districts have the authority to set those thresholds, but everybody within the district that has to conduct a health risk assessment has to use the same method to do that.
Okay, so the method being the same, but if you have, say you have a community person, member, resident, or what have you, that has been historically in the very same location, and then they move to another location that also is contaminated, how are you assessing the real risk if they've got already historic exposures and then they either move to another area that is just as toxic, if not more? How are you calculating those risks? Or is the flip side being you have new folks that come into the area and they haven't been exposed as long as someone else? My understanding of risk assessment is that you guys are not actually calculating the risk, the current risk that already exists, whether it be a pregnant mom, an elderly person, someone already with compromised health. You just sort of take that standard at where it is and then calculate from there, what are those thresholds and levels? So how are we to be confident that these numbers that you've come up with these cancer risks are what they are? Because our communities and our bodies are saying different. It seems like when you talk about this high level, and that was the other thing, but I'll ask that at another time because you guys keep saying the term very high level, you know, of understanding here. Well, I need it to actually be low level, simplified, you know, so that I can really understand and follow this process. But from what we're seeing in our communities, and the cancer rates don't seem to be matching the cancer rates that you guys have come up with these calculations. So I'm just trying to figure out, are you taking into account the historic exposures for many of us that have been born and raised in our communities, those levels of exposures?
Sure. I guess the short answer is no, we don't take that into account. That's the calculation methodology wasn't intended to do that. The way we calculate risk is we base it on, we make the assumption that someone, a resident, for instance, if we're doing residential cancer risk, has lived in that home or lived in that facility, that community, that one location for 35 years. They were born there and they've stayed there. We don't have any way really to do what you're talking about, which is to say a person was exposed to a certain level in one location for a certain portion of their life, and then they move and they have new exposures for the rest of their lives. We really have no ability to look at that type of change of exposure or track an individual person's lifetime exposure, you know, as they move around. We just say, in general, in this community, the folks that are living in this community are exposed to this level of risk. To address the second part of your question, which is to say, why is there a disconnect between what we're predicting and what you're seeing? Again, the risk methodology, this calculation methodology, was designed from the beginning to look at a single source, a single facility. And you guys are exposed to many sources of toxins, many sources of carcinogens. So you're not going to see a direct line comparison between what's predicted from a single source, even if you took multiple sources, and the type of cancer rates you're going to see in a community. And that is why we're really seriously looking at how are we going to start evaluating cumulative risk, because your exposure isn't just all of the stationary sources, even those that are accounted for and not those that haven't been accounted for. It's also mobile source, cancer risk. So all of the freeways running through your neighborhood, off-road equipment. There's just so much that needs to be accounted for that this particular methodology doesn't account for. It was never really intended to be more than just one facility at a time. Does that answer your question?
I was going to say it wasn't letting me unmute.
Okay.
Yeah, I guess it does. But then if that is the analogy, then how are you coming up with a cancer risk for children in that they're in the womb, and not calculating for the fact that their parent or parents could have had exposures as well? Again, it just seems to me that the old way of doing risk assessment is antiquated and outdated, and it is really not serving the best interests of disadvantaged communities. And we're talking specifically these historically disadvantaged long-term communities who are primarily African American. We are still left out of the equation. And so at what point do we stop following a process that we know is not really benefiting us and giving us really the wrong data? Like, how come we want to just keep going down this road and it has failed us all these years, no matter how many processes we use, whether it's CEQA, NEPA, or whatever? It is still not evaluating true numbers in what we're seeing in our communities.
I mean, I agree. The part of the reason for having the discussion on the 10th, on May 10th coming up, is to talk about this exact thing, so that we can understand better. I mean, it's not that we don't understand. I wouldn't say that. We want to hear from all of you about what you're experiencing. If there's a way to change the way we're doing this type of health risk, and a way to improve that to account for whatever else we can account for. And I really can't even begin to give you a list, but we want to try to start exploring that. But really, truly, to get to your lifetime exposure from all of the sources in your neighborhoods, we need to get to the point where we can conduct cumulative health risk assessments. And then once we've been able to do that, figure out what we're going to do with those numbers.
Right. And last but not least, I want to add in there too, and especially since all of the agencies point to OEHA and their new Callan viral screen and score, again, we're very concerned because we have historic locations. For instance, one of my former communities was Midway Village in Daly City. My understanding is they're renaming it. So, and many of the folks that have lived there have died and passed away, right? So for the new generation that's coming up, or those of us that, you know, the new, let's say the younger generation, or those that get into environmental justice or whatever and want to understand what sort of exposures exist, you are changing the name. The data seems to be disappearing. Different locations, and it's not just Midway Village, even over there in Hunters Point, they talk about renaming Hunters Point or certain areas over there. You go on the map, OEHA's map, and you're not seeing these most vulnerable, most toxic areas listed on that map for people that are trying to do the research and understand it. You're still not getting an accurate, transparent understanding of where the highest level of contamination is and what those true exposure rates are. And then I'll end it there because I'm sure others want to talk.
Well, I do want to address one of your points too, LaDonna. I can't answer everything. I honestly can't. We need to move in that direction. We're working on a couple of tools here at CARB to help communities understand that exposure and understand not only what your exposure is, but what you should be worried about, if you will. In other words, there are things that you may have a number of contaminants that you're exposed to in your community. Which of them is the one that you should be most worried about? So if you want to think of it that way, just to help you understand what your exposures are, but also what your risks are. So we're working to develop that. There's some other new tools too that we're going to hopefully provide to help you understand the rates of emissions in your community, where those things are, not just the rates, but geographically where they're coming from. So hopefully we'll be able to start giving you the tools that you need to understand that. But right now we're working on it, and I'm afraid that's the best that I can say. So who's next? Is it Lily?
Lily's next.
Okay.
Hi, thank you for letting me speak. I just wanted to address and share some of the concerns that I heard echoed from OEHA's perspective. I am a toxicologist that works on community air protection from the statewide lens. So I've been involved in several different AB 617 community meetings. I recognize several names of some of the EJ voices that I'm hearing even in this space. And so one of the things that, to your point, LaDonna, that I hear, and to also Matt's point about needing to develop a lot of these newer tools, we do recognize in the scientific space at OEHA that some of these, historical built environments are things that need to be addressed in our chemical risk assessments, health risk assessments. We are working on the framework with CARB and other agencies under the Cal EPA umbrella, which is where John Boudreau shared that OEHA fits in as like the scientific support for all of these different sources of exposure, such as air, water, soil, which is, CARB, water boards, DTSC, and the others. And so with that, the kind of coordination that it takes to develop the science to fit into the regulation to protect the public health, that is something that is very on our radar. And also at the federal level, it's also being worked on at US EPA. So with all of these kind of different segments of government, federal, state, local, it does have to all fit together. And so with that, that's where, as frustrating as it can be to wait for it to be developed, that's where I can see, at the air district level, for example, because I work on 617, they're waiting for the state to come up with something. And the state is also waiting for the federal framework. So this is where it needs to be coordinated. And this is where the sharing of our community level understanding, which is growing. We don't have all the pieces yet, but this is where the resolution of information comes in handy for us to come up with a statewide framework so that the local air districts and whatnot, the other local government entities can make it fit within the framework that we as a state have to fit in at the federal level. So that's just what I wanted to share.
Thank you, Lonnie. And Lonnie, you have your hand up?
Yes, just to piggyback, good evening. Thank you for allowing me to speak. Lonnie Mason, first generation, Executive Director of First Generation Environmental Health and Economic Development based out of the Bayview Hunters Point community. And just to piggyback off Ms. Williams in regards to the health assessment, I have to give a couple experience because I understand what she's saying when we talk about long-term, risk. I give an example. My auntie lost my little cousin, her son, at the age of 5. He had a tumor in the back of his head and they couldn't operate on it. She was born in Hunters Point, just like myself. And so my little cousin couldn't get operated on, but I'm sure it has something to do with the area because she was right there, right next to the shipyard, the Hunters Point shipyard. And that's where she was born, as well as my father. And so, and the rest of their siblings. And not only that, I just lost a cousin. She was around 65 years old. She was a flagger. She was doing a lot of construction work there in the area. So you have to understand, she didn't have no mask at the time, but she died of lung cancer just recently. And then you have my little cousin at the age of 5. So what she was saying, mothers being affected while they are pregnant. This is something that is going on in that community, and that's been going on for years. And not only that, we have a cement plant that's been operating in the Bayview Hunters Point community for 20 years without a permit. And then you put a homeless shelter right near in the surrounding areas with Recology and Hanson and the cement factory. These are the health risk assessment that need, I'm trying to let me calm down. This is ridiculous. Something needs to be done about that. That's a serious issue.
Yeah.
This has been going on for years in the Bayview Hunters Point community, and no one is doing anything about it. People are dying. I could go on about the breast rate, the breast cancer rate. I know 6 women that have died of breast cancer in the Bayview Hunters Point community. There's an issue. There's a problem. So I'm just letting you know. I could go on and on. I can go on and on about what's going on in that community, and I'm sure you guys are totally aware of what's happening. I don't know if you're aware of what's going on in regard to that cement plant and the homeless shelter there, but everybody wants to put it on the city. Say, oh, in San Francisco. So where's the health risk assessment there? Why hasn't nobody gone there to take care of that, to find out what's going on?
Yeah.
You see where I'm coming from?
Oh, absolutely. Yeah, I do. I
Okay.
understand. Yeah.
All right,
No, and I wish I had an answer. I wish I did. That is what we hope to get to. We're hoping to get to the point where we can start addressing these larger community level exposure issues, understanding them and then doing something about them. And I don't want to sound, and it sounds bureaucratic, so forgive me, but there's sort of this mixture of responsibilities. Oh, Cassie, did you want to address that?
Yeah, hi.
Good.
So I just wanted to say, Lonnie, we hear you. I know we met with you, I think it was back in September, October timeframe, and got all your questions about this. And Matt's actually been working with us to answer your questions about what's going on here. I recall that you had some questions about why is it that the residents aren't notified? How is it that these facilities continue to operate and come in?
Exactly.
Why is it that, you know, someone isn't stopping this? We are working with the districts to take a break, pause, deconstruct the program and explain what's happening. And I think what you're going to see when we put out the answers is that sometimes the regulatory construct isn't there right now to address some of these concerns. And that's a problem. So I think for us to be able to move forward, we need to pause and say, what tools do we have in the toolbox? What can we do? And what are these tools not doing? Where are the holes? Where are the issues? And I think we're seeing that. We're actually hoping within the next month to have the next set of questions out. A lot of them are on HRAs. A lot of them are on health risks and notifications. And I'm hoping that at that point, then we could have a conversation about what's next. What needs to be changed? Is it individual state policies that we need to see revised? Or a lot of time, is it the statute itself? So I just wanted to let you know, we absolutely hear you. We're working towards it. And there's something that definitely needs to be done about all of this.
But in the meantime, that's true. But in the meantime, people's lives are really at risk right now. I mean, seriously, because those sand dunes are high, very high. And that's, to me, that's environmental racism, to put those poor people, and the majority of those people are Black people that are living in that trailer session. It shouldn't be that way. And the rest of the community being affected as well. Something needs to be done about that area.
Yeah. And Lonnie, I get it. I mean, when I say it's personal, it's personal. I have family members that have cancer that live in disadvantaged communities as well. And I totally hear you. I just want you to know that there are people in CARB. They get it. They resonate with you. They have similar stories, and we're trying to do whatever we can. And there is no time frame that we can move quickly enough, but we have to do it within the constructs that we have. And I think, again, that's why pausing, deconstructing, and see what's not working is so pivotal on moving forward.
Okay, thank you.
Okay. Was there anything more that you wanted to say, Lonnie?
No, that was it.
Okay,
Sounds
thank
good.
you. Yeah, yeah. I mean, we do need your input, everyone's input to help us work, especially when we're working towards cumulative impacts analysis. We're going to need to be working with all of you at the community level, with those folks at the district, everybody. We're going to have to be working together to make sure that whatever it is we come up with, the tools that we come up with, and the policies that we come up with that determine what we do with the information once we've got it, do what they need to do. We need, we need to affect the changes that you're talking about. So I know it's going to be, no answer I can give you is going to be good enough, but we're working in that direction at least. Okay, so we've been talking about cancer, and because we also have talked about cancer, non-cancer, chronic, and acute, I just want to give you a quick understanding of how that's done or how that's calculated, and then the differences and why those differences exist. Non-cancer, chronic, and acute is calculated differently because the nature of the pollutants, and how, because of the nature of the pollutants and how they affect your body. So we calculate the risk from non-cancer pollutants by calculating something called a hazard quotient, and then adding up those hazard quotients to get what's known as a hazard index. You'll see the term hazard index, or HI sometimes. The difference between non-cancer and cancer is that for non-cancer exposure, we do actually differentiate organ groups or organ systems. Whereas with cancer, we just lumped all cancer together. With non-cancer, chronic, and acute, we specify which organ systems or organs are affected by that particular pollutant. So we wouldn't add together something that has, say, a chronic effect on your eyes with something that has a chronic effect on your gastrointestinal system. So we add up the effects, those hazard quotients, based on organ system, and then we get a value. That value, what we're looking for is to see that that value is less than 1. So the way it works, the way it's calculated, if the value is less than 1, then we don't expect to see any adverse health effects. There should not be any adverse health effects. That's the other difference between chronic acute and cancer. There is a de minimis level, a level below which you shouldn't see any disease. That being said, if the values are very close to 1, if they're even slightly over than 1, it doesn't necessarily mean that you're going to see adverse health effects. So there's some leeway in allowing things to continue even if the value is 1. But what we're really looking for are chronic and acute values less than 1. Okay. We've got about 15 minutes left here, so I want to go through a couple of things. I'm going to skip this because I'm going to come back to something very similar to it. I'm just talking about how that information is presented. I do want to talk about the role of the districts. Maybe I should actually put it to you guys because we have only 15 minutes left. Do you guys want to hear about the roles of the districts and what it is they're responsible, how HRAs are used there, and the same thing about CARB? Or are you already comfortable with that information? And I'm going to do this as a show of hands. So if you want to have me talk about this, just raise your hand. All it takes is one hand and I'll talk about it. If I don't see, if we're, okay, sounds good, excellent. Okay, so the air districts are responsible by law for stationary sources of criteria pollutants within their boundaries. Okay, they do that, they control those emissions by creating rules and by issuing permits. They also have a role in toxics. So the takeaway from that very first bullet point is stationary sources and criteria pollutants. Just real quickly, if you're not familiar with the difference between criteria pollutants and toxics, criteria pollutants are a limited number of non-toxic pollutants that include oxides of nitrogen, oxides of sulfur, carbon monoxide, particulate matter 2.5 microns and smaller, particulate matter 10 microns and smaller, and VOCs, volatile organic compounds. Okay, that's it. That's the list. At least that's the list that's used at the district level. Okay, there is a huge list of toxic compounds. So they're responsible for controlling criteria pollutants, but they do have a role in controlling toxic emissions in the AB 2588 realm, in their role in AB 2588. Sorry, hang on, just real quick. Yeah, let's do that. They also have a role in collecting the information. So they prioritize facilities, they review the HRAs, things that we've talked about already. They also collect information about the emissions, the toxic emissions. So they collect that together. Typically it's every 4 years, but some districts stagger that. But then they send that information to CARB, and CARB collects it together in a database. They also have a role in reviewing and commenting on CEQA documents. So again, I'm going to go through this really fast. If you guys want me to explain this in more detail, perhaps we can talk about having another session or something like that, but really, really quickly. There is another place where districts may do health risk assessments. Districts have several broad categories of rules, but the two that are kind of most important for our discussion are new source review and prohibitory rules. New source review is a series of rules that the district adopts that specifies what they have to look at when they do an engineering evaluation on an application. When they evaluate an application for a permit, they have to look at certain important key things. That's spelled out in the NSR rules. And some districts have one and some districts have several, but they all include the same components. And then there is another group of rules that are referred to as prohibitory rules. And I know it's really hard to see on this little tiny slide, but they're rules that are specific to a certain class and category of source. So for example, there's incinerator burning, there's orchard heaters, there's boilers of various sizes there, flares. So what those rules do is specify specific emissions limits for criteria pollutants from those sources. Okay, so whenever you see an authority to construct or a permit to operate, you're going to see references to some of the prohibitory rules, and you'll see references to the NSR rule. The role that health risk assessment plays in that evaluation of that permit application is that if the district recognizes that there are toxic pollutants coming from that particular source at a facility, when they receive that application, they're going to evaluate how much of an increase in emissions of that toxin there may be, and actually conduct a health risk assessment to determine what that increased risk would be. And then compare that increased risk to a much lower threshold level. So for the entire facility, typically it's 10 in a million. For permitting purposes, they may look at the emissions coming from the change that's proposed. It's not the entire facility, it's just whatever is being proposed as a change, and find out what the health risk is for our example, cancer risk, and then compare it to a much lower standard, for instance, 1 in a million. And if the proposed change exceeds an increase of 1 in a million chances per million of cancer risk, they may deny the project and say, go back and figure out how to make that lower. So there is a role for health risk assessment in the NSR permit process. Okay. I'm actually going to skip this. It's just an explanation of the difference between authority, construct, and permit to operate. If you're interested in what those differences are, I'd be happy to explain them. Okay. Later on. So if you want some additional explanation, you can contact me and I'll be happy to explain that. Again, districts have a role in AB 2588. Again, they're the ones that prioritize the facility. They do that calculation. Once they've identified that a facility needs to conduct an HRA, that facility either conducts the HRA or hires somebody to conduct the HRA. And then the air district is responsible for reviewing it for completeness and accuracy. And then they also have a role in the California Environmental Quality Act. So whenever an environmental environmental impact report is done, it's going to identify impact on various resource areas. Because planning agencies, because land use agencies aren't experts in air quality, it falls to the air districts as the experts in air quality to review the analysis that was done for air quality. And we also do that typically, depending on the type of geez, I'm blanking, sorry. My dog's banging the ground behind me. Kita. For the type of project. So we focus more narrowly on projects that have to do with freight movement. But the districts will review that, and they'll review two things. What's known as the air quality impact analysis, which is looking at criteria pollutants. And then if there are toxics present, they will also review the health risk assessment. It may also be that they'll review the project, identify the fact that there are toxins coming from the facility, and specify, and let the lead agency know that health risk assessment wasn't done and one should be done. So they may comment on that. And they may also comment on things that are called mitigation measures. So just really quickly, whenever a facility exceeds the district's significance thresholds for either toxics or for criteria pollutants, that the applicant has to identify ways that they're going to reduce those emissions. And those are referred to as mitigation measures. If the applicant states that they're going to exceed the significance thresholds, and no matter what they do, they're still not going to get below the significance thresholds, they'll say that it has a significant and unavoidable impact. In those cases, CEQA requires that the facility implement all feasible mitigation measures. So the district may review all of those measures and comment on whether or not all feasible mitigation measures were proposed and should be implemented. There are a number of other things too that they might comment on. Okay, so that's district responsibilities, high level overview. We got 5 minutes. I'm going to do CARB's responsibilities, and then I think we should probably talk about some of the questions that are coming in too. So our responsibilities are kind of everything that aren't the districts, if you want to think of it that way. So we are prohibited actually from controlling stationary sources with the exception of toxins. So we control things like mobile sources, on-road and off-road, portable sources, consumer products, and specifically stationary sources that are sources of toxic emissions. So we can write regulations for stationary sources, but only within that realm. So to do that, we create rules. And we have a role also in AB 2588, just like the districts, and a role in CEQA. Okay, so as an example of the types of rules that we create, we have the authority to write regulations that set emission standards for mobile sources, and we have the authority to write regulations that control the emissions of toxic air contaminants. So these are two examples of those types of regulations. We've recently enacted the ocean-going vessels at berth regulation, which is both a regulation on the emissions from a mobile source and emissions of an air toxin. And then an example of a stationary source regulation or airborne toxic control measure is the airborne toxic control measure for chrome plating, which controls emissions of hexavalent chrome. So that's a stationary source, which would typically be under the jurisdiction of the districts, but because it's a source of toxins, we write those regulations. Whenever we conduct these, or whenever we write these regulations, we typically conduct a health risk assessment to quantify the benefits, to show how much the reductions in emissions will reduce health risk, and in particular cancer risk. So this is an example of how we kind of show that, how we demonstrate the benefits of a particular regulation. So what you're seeing here is two sets of lines. One would be the health risk in 2031, assuming we did nothing. We left the existing regulation as it was. And the health risks in 2031 with the proposed regulation, which is now the current regulation because it was adopted. So what you're seeing here is this, I know it's hard to see because it's small, but there's this dashed blue line up here, kind of stops and picks up again here. That's the 5 in a million cancer risk isopleth. And this is around the ports of LA Long Beach. Oh my gosh, sorry. LA Long Beach, okay. So the dashed blue line is under the existing rule. The solid blue line would be the 5 in a million under the proposed rule, so on and so forth. There's the green line, that's the 10 in a million, the green line, that's 10 in a million under the proposed rule. So the idea here is to demonstrate not only the effect of enacting the regulation in terms of reducing cancer risks, but also reducing the geographic exposure, the distance out to which we have those levels of risk. And in this particular case, there was with the old regulation a 50 in a million chance of cancer risk that was immediately around the port area, and that completely dropped off with the new regulation. I'm not showing you this because I'm trying to blow our horn. I'm just saying this is how the information can be used to explain the benefits of a regulation, and how we help people understand both the greater extent of the reductions and also the geographic extent. Okay, we also have a role in CEQA. Our role is very, very similar to the districts. So we look at the same things: air quality impacts analysis, health risk assessments, and mitigation measures. I know there were quite a few questions about what you can do with CEQA and how health risk assessments play in when we were looking at that first polling question. So if there is a health risk, if there are emissions of toxic pollutants or hazardous chemicals, those have to be quantified under CEQA. So they're going to need to do a health risk assessment. That health risk assessment may show that it's very low, but if it's there, they have to do it. Okay, so that if you know that if you as an advocate are looking at a draft environmental impact report, and you know that facility, for instance, has heavy duty diesel trucks going to it. Diesel PM is a toxin. If they haven't done a health risk assessment, that's something that needs to be flagged. It's something that we would flag. I'm sure that's something the districts would flag. The other thing that you can look at as community advocates in the CEQA realm is to look at both the air quality impacts analysis, and this is something we do, and the health risk assessment, and check and see if they're using the same assumptions for both. Sometimes you'll see different total numbers of truck trips or different trips distances for the air quality impact analysis than those that were used for the health risk assessment. And that isn't always necessarily because someone's trying to deceive us. It just may have been done by different people. There are some valid reasons for that, but if those are different, they need to be called out. So there are things like that we can do. And then mitigation measures. Again, there is this question of all feasible mitigation measures. We really push, and I know many of the air districts do too, push on people when they're pushing back because they say it's not feasible. Feasibility is something that we can argue over, and it's actually defined in CEQA. Okay, it's actually 5 o'clock now, guys. I'm really sorry. I know we've gone long. Amanda, what do you want to do next?
Yeah, so in case anyone needs to hop off now, if before you leave and you would like follow-up information, if you could send me your email via chat, that would be great. Also, we do have a survey to evaluate this session and see what you'd like to see in the future. So I put those links into the chat. And if you can do that survey when you have time, that's great. You will see the 2 first questions again, so I'm sorry for the repetition. But for those who can stay, I think we'd like to have Hillary share the meeting notes from today and just share some of what we heard and what questions were captured. If you could do that for us, Hillary.
Yes, let me share my screen.
Stop sharing mine.
Can everyone see this Word document? Great.
Yeah.
So I tried to capture the discussion, the questions and the comments that participants had asked and talked about today in this document.
Matt, anything from these that stand out to you?
I mean, cumulative risk is always going to be one of those things. It's one of those things that's good. We're going to be talking about a lot over the immediate future. I guess I just want to make sure that can we just kind of scroll through them, Hillary, and make sure if you guys have a question that we didn't capture, please let us know. And then
could you zoom in on that, please?
Yes.
Just on the whole page.
How's that? Better? Sorry, should I have zoomed out or zoomed in? The document is actually multiple pages, so I can slow very scrolly. I can scroll very slowly.
Sure.
Does that work for everyone?
And one of the things I wanted to let you all know too is that we're going to be going through the chat room, through all of this that Hillary captured, and we're going to put together a Q&A based on this session, where we'll attempt to provide answers to all of your questions and then post that so everybody has that as a reference. Anything that is relevant to the work that Cassie was doing, her group is putting together that Q&A that she mentioned that has to do with the roles of the air districts and the permitting process. We will add those questions that are relevant to that question answer, to that question answer list as well. So you'll have it in either place. And then while Hillary's scrolling through here too, I wanted to take this opportunity to thank you all for being here. Thank you for participating. Thank you for sharing. Thank you for I know that sounds kind of, forgive me for sounding glib. That's not what I meant. Thank you for asking questions. We need to have a regular involvement with all of you. That's what's going to produce the best results. So I really strongly encourage you to continue to participate, invite you to participate in the session that's happening on May 10th. And it doesn't necessarily have to be within the boundaries of these specific sessions either. We need to engage with one another. And I know you all as community advocates have been trying to engage with all of us at the governmental level for quite some time. We just want you to know, at least at CARB, and I know the folks at OEHA feel the same way. We really want to have that discussion, that relationship, that engagement, and get to some place where we can address your concerns and find ways to help. So thank you for being there, and thank you for participating. So from what we've seen so far, does anybody have any questions, at least, that they wanted answered that they don't see on the list?
I think there have been a few more questions or comments in the chat as well that I haven't recorded yet. So those would be, I would add those as well.
That's fine. Yeah, and we'll grab this from the chat. So, and you guys can add questions to the chat too. Will that stay open for a while, Amanda, or does it close as soon as we're done?
Yeah, there are a couple more questions from Cynthia in the chat. But I think we also did want to offer to stay on after 5, but we do want to be respectful of those who only have till 5 p.m. So I'll leave that up to you, Matt.
Yeah, I'm here for as long as you guys want to ask questions.
Matt, and real quick, can I add that as we're going through and answering questions, we're also adding questions as we find gaps in the questions that are asked. So in different places, and I'm sure this is going to be the same for Matt's effort, where we see something like specifically about something like facility prioritization, and it jumps from like an HRA to facility prioritization. We're trying to fill in the gaps so that you have the whole story. So I just wanted to point that out. Don't feel the need to ask every single question. If there's something that's really missing, and the air districts have been helping us do that too as we move forward in answering your questions.
Yeah. Cynthia, I saw you just turn on your camera. Do you have a question? Comment? There you go. You got it.
There we go. Well, I've just been really observing. It's always very depressing to hear from my colleagues and communities and how, people have died waiting for change. And so I think I personally am glad to see CARB and OEHA moving in a different direction than what I've seen in the past. I see some real empathy, and that's appreciated, but I just really want to have a better understanding of what other options, are we looking at to, try and define what's happening in our communities, not only to clean them up, but to stop the onslaught of more coming in. And I hope that there are other options, because I think people have been very good at articulating how risk assessments do not serve them. And I just would hate the agency, to keep holding on to the rafters of this boat that's falling apart here while we're in rough seas, and look more at some of the things that communities feel. I know, years ago, Mary O'Brien wrote a book about options assessment, where you broaden how you look at things. And so I just hope that the agency gets to the point where they're more confident in saying no to a lot of the pollution that comes into our community. And that will only give us the breathing space to try and dig in and clean up what's already there. So I apologize for being late. I thought this started at 4, but people have it. People have it well under control, and I'm just observing as a really old person, hoping to see change before I too die. So thank you for taking my comments.
Absolutely. Yeah, and Cynthia, please, join us on the 10th as well. I mean, I know you had input in the last session and some insights that I think we'd be very much interested in hearing. And to kind of give everybody who wasn't involved in the session in December, one of the things that was brought up was exactly what Cynthia is talking about, that the methodology that we're currently using doesn't account for everything that we could potentially be accounting for. It is what it is. It is the tool that was created to answer the question at the time back in the early or late 90s. And that was to come up with a way of quantifying risk for AB 2580 purposes. And the whole point of the discussion on May 10th is to talk about what more we could do. Is there a way to take this tool and improve it to the point that it's useful in the ways that you guys would like it to be useful? What else do we need to do? And it's going to be an open conversation. There are really no limits on what we're going to talk about other than to talk about health risk assessment. But we really want to do, what we want to do is hear from you. And I'm guessing that since this conversation is that conversation is going to bring up a lot of stuff, it's probably not going to be the only conversation we have along those lines. We're going to probably have to do that multiple times to really get to what we need to do. So Moses, I'm sorry, you had your hand up.
There we go. Thank you, Matthew, and everyone involved. Thank you for participating. Obviously, this is a collective effort, and I agree in echoing Cynthia's. I consider myself as a frontline person here in pollution, and to see and hear you guys' knowledge and expertise. I'm relying heavily on this amazing knowledge and engagement in helping us identify these issues and problems. I did want to expand a little bit on what we're working on, and I want to share this in the chat real quick. This came from an environmental review document here in the city I live in Paramount, that there's a company that's going to change its business. But I wanted to read in it and saying that due to significant and unavoidable impacts in air quality hazards and noise, and the location of high density minority and poverty areas near the refinery and along the pipeline route, the project would disproportionately affect minority and low-income populations at levels exceeding the corresponding medium for the area in which the project is located. So I think that's pretty much sums up, I believe, I'm sure most of you agree, what we're fighting for. It's, you can see that these projects and these companies that have been or are starting up, that that we have to bring that into the conversation, where obviously interests, special interests, politics factor in, and this particular part of that review will probably not make an impact on the decision. I can tell you with great confidence this project is going to go forward, and this particular statement is just going to lay in the middle of that multi-page document. So I'm hoping, and I know that we will, stay positive, that as we go from the macro level, as we're saying, from federal down to state and then getting down to local, to really get some teeth in this data, this information. Personally, again, here at the front line, that's what I'm looking to learn and to use to go forth and with this to this particular company or this conversation when they get in the decision making and say, hey, here's the impact of your what is going to happen when this operation happens, the diesel particulate matter, whatever the business is doing. From, as I've mentioned before, my personal experience, I was exposed to hexavalent and chromium for the majority of my life. So thus the cancer, thus where I'm living at, and then you start adding all the other stuff, the new businesses that factor in, large warehouses, train, so on and so forth. You can go off the list. So how can, in drilling that data down, and I see this as a great opportunity as we continue this conversation and merging this knowledge to really, and again, get the teeth to down where these companies that start doing their business to really hold them and say, okay, this is what you're going to impact. You need to do all the mitigating, all this processing, the training and all that. And on the other end, those that skirt or just, keep their nose up at us, that we say, okay, here we go forth with this information down to say to the macro level where I'm at, you've been spewing this out in the air. You've been putting this in the water, the ground, so forth. And here's the data. Here's the information that we've collected from, as we've been talking about the WEHA reports and then CARB and down to the air district, and merging that all together work together. And I just wanted to say that, to throw in, and as everybody involved, it is a united effort too. It's specifically those companies that really are just, giving us the finger and saying, we'll do what we want to do, and we'll deal with the consequences later. And here I am sitting dealing with the consequences of their inaction. But thank you, Matthew, and thank you, Amanda, as well, for keeping me in the loop. And you got my back. I got your back. Got your support. And I think it's a team effort. Thank you.
I appreciate that, Moses. Thank you. Anything else? Any other questions or comments anybody wants to make? Okay, well, hearing none. Again, thank you very much, everyone, for participating. We really appreciate it. We appreciate the opportunity to have this discussion. I hope the information that we covered today was useful to you. Again, I encourage all of you to join us on May 10th for that open discussion. I think it's going to be really interesting. I think there's potential for some really interesting things to come out of that. Again, if you have any additional questions, things that pop into your head after this is over, please feel free to send those to us. You can send them either to Amanda or to myself. Let me share my screen real quick. Do they have the handouts, Amanda, or do I need to?
The handouts?
Yeah, I just want to share our contact information.
Oh.
Yeah, so there's mine, and Amanda's is right there. If you send it to her, she'll get it to me. If you have questions about a WEHA's role or anything specific to the methodology, you may want to contact John. You can contact me too, either way, or you can contact John directly. John, I'm sure you appreciate me giving your name out like that. And then Amanda, do you want to say something about the last bullet point there? The environmental justice blog.
Yeah, that's another good place if you aren't subscribed or looking at the EJ blog already. Every event that our division hosts, most events should be published through there, but every event we host is going to be advertised through that EJ blog. And there's also fact sheets that go up there as well. So that's a good resource if you aren't aware of it already, and I'll put the link for that in the chat.
Sounds good. Okay. Well, if there aren't any additional questions, I guess we'll call it a night. Thank you again for the third time but for participating. It's valuable, very valuable information. Okay, and have a good weekend. Have a good evening. We'll talk to you later.
Thank you, everyone.